Thank you. What a great day today's been. It's been really terrific for me sitting in the audience, and it's great to participate. So as you heard, I started my professional career as a pediatric ophthalmologist. I still practice today. And then I segued into this quality role where I help lead a physician group of about 1,300 physicians in their efforts to improve the quality they deliver, the care they deliver to patients in the Washington, D.C. area here at Kaiser Permanente. So my professional background has gotten me really used to people crying on a regular basis and not letting it affect me at work. Because what wasn't clear to me in this quality role is kind of being a grief counselor to a degree and taking people through the process of performance reporting. And so what I wanted to talk today about is my kind of process of performance reporting and how I take people through it. It doesn't work for everybody, it just happens to work for me. So really, the first thing that I'm always really clear with physicians and with nurses and healthcare providers is the difference between targets and goals. And your goal is what you desire your improvement to lead to. You know, improvement is defined as moving from the state of one being to a different state of being that's better. And so in order to do that, you actually have to measure, right? I mean, that is the NCQA, measuring quality. And that idea of measuring healthcare quality for a large segment of the healthcare industry is still foreign to them and still really scary. So we have to take them through the process. It's the only way for our industry to improve. So the difference between targets and goals, goal might be, you know, let's reduce hospital readmissions. And targets are really your interval places, maybe your process measures and your path to that goal. And it's really, really important when leading quality in a clinical space to always refer back to the goal. If you only talk about the targets, what's going to happen is people are going to coach to targets and perform to targets. And as soon as you reach them, they'll stop. So if you're trying to get to, let's say, breast cancer screening of a certain level, and you coach to the target, they'll stop once they reach that target. But if you're the woman who came after they met their target, the effort's not as great. That's not where we want to be. So you always have to talk about goals in the messaging. So taking that kind of in stride, what you have to do next is define what you're going to work on, define what your measurement's going to be. And if, you know, I'm very, very fortunate. I actually get to work in an environment where performance measurement is commonplace. I have a medical group that we actually embrace it. We weren't always that way, but every new measurement, every new thing that we're going to work on goes through the same process of socialization and then kind of the reaction that comes with it. It just doesn't become part of the routine every time you start something new. So the first thing that I always start with is whatever new thing we're working on, I always start, the first data point is how do we do as an organization? And how do we do, fortunately, hopefully there's a national benchmark. So how do we do compared to them or to the national benchmark? Using the same criteria, the same measurement methodology, as close as I can get it. And you just put that dot up. And you let people absorb it. And you let people kind of take it all in. And then you start segmenting that performance. And the next thing you do is say, okay, how do we do against that national benchmark by gender, by age? Sometimes we forget age, but by age, by ethnicity, by race, and now, you know, even by product line. In other words, is it Medicare, Medicaid, Affordable Care Act, Marketplace, commercial? We can splice, we can dice, and we can compare to those national benchmarks. And when you do that and you release that, you're going to get the interested few engaged, and they'll start asking you questions. You won't get the groundswell reaction, but you'll start to get some feedback, and that's good because, you know, as everyone says, feedback is a gift. And so you start getting that feedback, and you start tweaking your message, you start tweaking your measurement, and then you have to make eventually that pivot where you start measuring by healthcare team or provider. And that's where you start getting into the scary space because it's a little bit threatening to people. And so what I'd first do is I send out that information kind of de-identified or blinded. So I just let everybody see it and take all that in and kind of say, and there's a protective mechanism. Most people don't assume that they're the worst. They just kind of figure somewhere in there. Someone introduced a concept to me a few weeks ago. I know I'm late to the game. This idea of illusory superiority, where we all think we're better than we probably are until the data tells us otherwise. And so let me kind of illustrate that for you. How many people in this room can sing? Show of hands. Okay. How many first graders, if I asked that question, would raise their hand? And so what's happened between first grade and today for you? Somehow, experience or the data has proven otherwise. Now, I would actually love for don't sing now, but I would love for all of you to feel you can sing. Because in moving quality improvement, you gotta make sure everybody at the end of this feels that they can sing. But we need to give them the feedback, the data, to tell them how actually you're doing. I know Laura talked about it earlier. Isn't it crazy we actually don't know how people are doing right next to us? So after you send out that de-identified information, the next phase, drum roll please, is identified, unblinded information. This is how you and your healthcare team is doing compared to your peers. And so that day that we make that pivot, I usually kind of do this. And, where's Dr. Territo? I think he left. We haven't seen him. Now, you have to be brave. You have to stand behind your measurement. You have to stand behind your data. And you have to then, what I call, walk people through the 5 stages of grief. And I'm not the first person to talk about this, obviously, in healthcare, but I just I see it over and over again. So the 5 stages of grief, what's the first reaction is denial. And I call that blame the data. The data's not right. Your data's, and then it becomes my data. Your data's not right. You sent me a list of 1,000 patients that you said I didn't do something. I found one that I did it. Your data's wrong. I'm throwing the whole thing out. It's done, which leads very quickly and sometimes simultaneously to number 2 reaction, which is anger. And I call that the reply all reaction. You, Dr. Territo, your data's not right. And I'm telling everybody. I'm telling everyone you sent this to. I'm telling your 2nd grade teacher. I'm telling your cousin in Minnesota. I'm telling everybody. And you actually have to react to that, because a lot of times they're right. Your data isn't right. And so how can you lead performance improvement if you actually don't have good data? So you actually have to take that in. You have to go back and fix your report. Because if you don't, they're always going to throw away your information. But you also have to correct them if they're wrong. And you have to actually respond and say, yeah, actually, it was right. You kind of put that information someplace that nobody would find it, and you actually assumed that something was done when it wasn't in the medical record. So how am I supposed to read your mind? Politely. So, which then leads, after you get through that, and that can take a while, maybe a couple of rounds, you get to grief stage number 3. And grief stage number 3 is bargaining. And I call this phase blame the patient. My patients are sicker. Your patients aren't as sick as my patients. My patients are sicker. Therefore, I don't do as well on this metric. So I've been in clinical medicine almost 30 years. And the first day that I walked onto my first clinical rotation was the first day I heard from a colleague, yeah, my patients are sicker than yours. I've spent 30 years apparently attracting the healthiest and the most compliant patients ever. So, yeah, my patients are not as sick as yours, apparently, but let's compare your patients who you think are ever so sick to your colleagues who are ever so the same right down the hallway next to you. And usually you'll see variation. And I love demonstrating variation. My team will tell you that I live and breathe by variation reports because it debunks myth, because it breaks down that resistance to, I can't do this. Someone right down the hall is doing it with patients ever so similar to yours. Let's find out how they do it. And let's move forward. Because the natural next phase of grief 4 is depression. And depression you can really get stuck on depression. And I would tell you more for quality initiatives that have to do with outcome measures than process measures. Because outcome measures are really tough. They take a long time. And so I come from a medical family. Parents are both retired primary care physicians. Sister's another ophthalmologist. We were all having dinner not so long ago for a holiday or something. This whole idea of measuring clinical quality came up. And the talk from all but me was, I don't understand how doctors could be held accountable for people's hypertension control. And I said, do you all realize what I do for a living? I mean, have I not shared that I actually do this every day? We actually can make it, and then they got the lecture, we actually can make a difference in patients' hypertension control. Our organization actually changed our hypertension performance in a very short period of time, and we didn't get a whole bunch of new patients. We changed what we did. We put systems in place to actually do things. We highlighted success where it happened and brought people who were struggling to that level of success. And that's how you break out of that depression. But you can really get stuck in depression because the next phase after depression, joyfully, is acceptance. And that's where being a grief counselor in quality comes in. You have to walk people through this process to get to acceptance of, okay, how now do I make things better? And that's really where people start to do amazing things. And you actually, I say this, and I don't mean to be flippant, I have the greatest respect for healthcare providers, and I think one of the greatest parts of my job is actually help them do what they do at new levels and unleash their potential. So, I think you have to respect your audience and whenever you're doing performance reporting. So you get to acceptance of how do you get things better. And that whole 5 stages of grief, it can take years, it can take months, but I will tell you, just this past week, one of members of my team actually had to speak to a grief-stricken physician who was dealing with a new performance report. He got off the phone, he said, hey, Dr. Territo, 21 minutes. I said, what was 21 minutes? He said, we went through the 5 stages of grief in 21 minutes. True story. I love that story. I have a whole team of grief counselors now. So how do you get people to a better place? And so the next phase is you actually have to help them. You actually have to give them a recipe. You have to give them the way and the means to do better. And sometimes the old way of quality improvement was just try harder. Just try harder. I'm a firm believer that that's nonsense. Just try harder. I think healthcare providers across the country are trying really, really hard. I think you have to model behavior, you have to show success, you have to put systems into place that support the right thing. I always tell everyone, make the right thing to do the easy thing to do, and you'll see great results. So the next thing that we have to do in this performance reporting that I think is our responsibility is the presentation of data so it's actionable. I think a lot of times people put up graphs up on a slide and you need, it's 6-point font and there are lines all over the place, and from a statistician point of view, it's a beautiful thing, but from a clinician point of view, it's malarkey. And you can't get everybody into the front row to see what you're talking about. So what I always tell my team is, it should be, and this is where I think my fine arts, visual arts background comes in. You can tell a story, picture's worth 1,000 words, it really comes true. Your report should stand on its own. you might not always be there to tell them the story, so your report should tell the story for you. That means clear data presentation, transparency about where the data is coming from, and a clear directionality of where they're headed. That seems really easy to do. It's not so easy. I took my team through a journey this summer where I actually made the request of them to standardize for every quality improvement effort in our whole portfolio, a standardized recipe, as I'll call them, for quality improvement. And I think that they can all testify it was not easy, but they stand on their own. We give them, when people have a question, they know exactly where we are, where we want to be, and what's driving our performance, good and bad. So I think it's our responsibility to do the digging, connect the dots for people, but also to show them that there is a way to improve performance and help them be comfortable with the fact that clinical quality can be measured. As again, I would say, it can be the most rewarding thing in the world if you do it, but it can also lead you to have some battle bruises. But just think the great outcomes that it leads to for patients and for people under our care. Thank you.